Hi, we'll be doing grand test 179 today, starting from question number 199. It's a question about great veins of kinds. They should be ligated very carefully to avoid hemorrhage. Catastrophic hemorrhage can occur in one certain surgery. So let's know about great veins of kinds today. So question 199. Great veins of kinds are seen in thymus surgery. It's an important draining vein of thymus, and this is a branch of left brachiocephalic vein. And this vein is an important vein that we need to take care of while we are performing total thymectomy, which is the treatment of choice when we are managing diseases related to thymus, which would be treatment of myasthenia gravis, where we have to do total thymectomy. So about great vein of kinds, it is important vein which is a branch, like I told before, of a left brachiocephalic, and sometimes even SVC gets involved along with left brachiocephalic vein. Since it's an important draining vein of the thymus and it's a branch of brachiocephalic vein, so we need to take care of this. And important things to know about thymectomy is that thymectomy has proven to be beneficial regardless of the age, even in older people. This should be the standard of care in cases of myasthenia gravis. So here usually what happens is both the lobes of thymus, they are related to brachiocephalic vein, left brachiocephalic vein, of which the tributary, one of the tributaries is the great vein of kinds. So we need to take care of this or tie it before we are performing thymectomy, right? Moving on to the next question. Here the question is about splenectomy. So the most common incision used. So most common incision used in splenectomy, question number 200. For performing splenectomy, various indications are there. The most important in surgery you will come across would be trauma, where we are suspecting massive spleen injury. There is a very definitive trend to conserve spleen, and till certain types of splenic injuries where the grades are there, up till 3 and 4 we try to conserve. Only when the pedicle is gone or the total spleen is gone, then is the time when the patient who had a splenic injury is persistently going into shock. That is the time to perform a splenectomy. And then there's always a debate between whether to perform a splenectomy or a splenography. We'll have a separate question on splenography later. Here we'll be dealing with splenectomy. Incision they're asking. So when we are performing splenectomy for trauma, here they haven't specified in the question why the splenectomy is being performed, but it can be elective or emergency. In elective also, there are a lot of advantages for going for a midline incision. Why midline incision is preferred is there are various benefits of performing a midline, though spleen is located in the left side and the subcostal incision is the one which is used by many surgeons. But then this, to a certain extent, this incision would restrict the management of very hugely enlarged spleen, where it's up till the umbilicus you can manage with subcostal, but midline always works. There are certain advantages, like I was telling. One is for really massive spleen, for which usually elective splenectomy is done. That is the approach would be easier. It would be easier to handle even for massively enlarged spleens. Another advantage about the midline incision is lesser bleed and easier healing, which is an important concern when we are performing such a surgery, whether it is elective or an emergency. And another advantage in case of emergency surgery would be You can even examine the rest of the organs. If they were damaged, you can take care of them using a midline surgery. When we are going for a subcostal, you're limited to just subcostal area, and you're limited to just left hypochondrium, and you can know the injuries in and around left hypochondrium. So there are a lot of advantages for a midline incision. So whenever this tricky question is asked, what is a preferred incision? Preferred is this, ideal is this, but is usually performed with subcostal when you know the spleen is small. So you have limitations for choosing a left subcostal incision. So such trick questions you should know, and you would be able to answer if you know all the details about the incision, choice of incision for a splenectomy. So moving on to the next question. Which is 201, which is not true regarding hemangioendothelioma of the liver. So three things here are perfectly fine. It's a rare tumor, more common in infancy. It is very vascular. Why it is vascular? You can know that it is a hemangioma. It's a vascular tumor. The name itself suggests that it is a blood vessel tumor. And endothelioma is a lining inside the blood vessel. So you know this is the vascular tumor. So these two choices, they look okay and they look all right. And also it involves both lobes of the liver because it's usually very large. So by exclusion, if you're not aware of these percentages, which would be really hard when we are struggling to remember a lot of percentages, so you need to know certain facts about hemangioendothelioma, which are true, A, B, C, and the D is the one which is incorrect. Why? Because there are 1/4 of hemangioendotheliomas which would be having. So moving to question 201, hemangioendothelioma. So vascular, fine, large, so must be involving both the lobes. It is usually large. It is in infancy, right? Because the name suggests hemangio, and endothelioma is the inner lining of the blood vessel, so it has to be a very vascular tumor. And the second important thing is infancy. It is usually a tumor of infancy, and also the third part was involving it, since they are very large, so it involved both the lobes. And in line to remember, another little thing to remember is only 1/4 are the ones which are extrahepatic. Right? So important thing, this is a third most common tumor of the childhood in infancy, and there is an extensive AV shunting in this particular tumor, right? So that's why it's very vascular, and it's a benign tumor, so that's why the spread is only in, you will see in 1/4 cases, the spread is only in 1/4 cases, usually benign. So these are the important things to remember. And where does it arise from? It arises from the mesenchymal tissue. Moving on to the next question. So 202, now they're asking about another tumor, which is cholangiocarcinoma of the bile ducts, and there's a very easy way to remember this, and you need to know the classification for cholangiocarcinoma. Cholangiocarcinoma classification is very simple. 202. So when we talk of 1, it is the common hepatic duct before the bifurcation, right? Common hepatic. So 1, this is what? It's a single duct, it's a common hepatic duct. And when we talk of the bifurcation 2, it's already by B, so it's second alphabet, and bi means 2, so that is second classification. So we have to choose the right answer over here based on that information that you have got now, which is, it involves the bifurcation without involvement of the secondary intrahepatic ducts. So answer goes B. Why B is 2, bifurcation 2, and the classification, since it is 1, 2, 3, and 4, so 2 is the bifurcation, so answer is B. And so what is 3? 3 is further divided into A and B based on whether left and right, since it has left and right. So based on that, left is B and right is A. Right is first and then B. So this is 3. When it involves the left secondary intrahepatic duct, it is, so we are assuming the liver is here, so that it's easier for you to kind of go down with the numbers as they increase. I have made it in a reverse direction. So this is the liver. They are draining the left and the right lobe. So 4 involves the secondary intrahepatic ducts on both sides. So 4 is both sides. Both side intrahepatic ducts. Right? So left and right hepatic, A and B, very simple, that's going to be 3 because bifurcation B. So what you need to remember is the bifurcation, and the rest will fall in place because the common is 1, and that's where the classification starts. So cholangiocarcinoma classification according to location, and the name of this classification is Bismuth-Colruyt classification. This is what you need to also know. Sometimes they might ask the name Bismuth. Colruyt, double T-E, Colruyt classification. This is based on location. So 1, 2, 3, and 4, 3 is A and B, left and right and left. So moving on to the next question. Again, this there's a question on spleen surgery, which is what of the following is not true regarding splenography. So grade 2 and 3 can be managed by suture repair. Can be. It's a trick question. It has got things that the choices is worded in a manner where you would get confused thinking this is incorrect. Why? Because 2 and 3, like I told, grades are not a severe grade, and there is a trend, there is a important thing to know that splenectomy is not what is performed right away, and repair is what is done, and repair also conservative management has to be done for any splenic injuries. Why? Because there is 2 and 3 grades are very little grades, and if the patient is not in shock, this is intraoperatively, if you find the grades to be 2 and 3, what would you do? Would you do a suture repair? So yes, you can go for suture repair, and they are usually pledgeted. What is a pledgeted suture repair? Pledgeted suture repairs are where, I'll show you using a diagram. So this is question number 203. Here the suture, since the spleen is a very fragile organ and it's very vascular, so what we do is there is a cotton pledget which is threaded through the suture. This is a pledget, and this would prevent the tearing of the spleen when we are repairing. So this is like, imagine this to be the spleen, this to be the hilum, and the injuries are like that, right? So if you take a suture, take a bite between this and this, there's a good chance that it will go tear through and it will come to this side, because it's very vascular, it's already bleeding, and it's already broken here. So if we place a cotton pledget in this area where the spleen is ruptured here, and then we take a knot, there's a good chance that it will hold, it will not tear through the broken spleen and the broken edges. So this is a pledget. So for 2 and 3, yes, we can go for pledgeted repair. When we see there is a tear in the spleen, the capsule, you can use a suture that has got a pledget in between, and then you can go through and take a tie over the cotton so the knot comes over here, right? So this is a little way of preventing any tearing of the spleen with the tight suture. So sutures have to be also not very tight when we are just trying to hold together the broken edges of the spleen, right? So, and then another statement given here is, let's examine other statements as well. It's saying at least 1/3 of the spleen should be preserved to maintain the immunologic function. This also seems to be correct because immunologic function is very important, and especially in children, the spleen is the one which takes care of a lot of immunological processes. So in order that to be holding true, at least 1/3 has to be preserved. And so partial splenectomy and rest can be managed by raphe, the part which is still not macerated, not broken, that it cannot be saved. And mesh wrapping for grade 4 and 3. So this is also, and what is the mesh used? Polygalactin mesh. This is the mesh which is placed over the broken pieces of the spleen and try to hold the pieces together, because these pledgets and these sutures would not really work here because the spleen is totally macerated and broken down, right? So this is what, so what is now left with? Use of argan beam coagulator is superior to other techniques. Though it is used, this is what is generally preferred to conventional techniques of coagulating, but then it has not shown any superiority. So this is a very trick question, but it had a lot of information in it, and that's why I have taken it in great detail about the injuries. First of all, we do not perform surgery if it is up till grade 4. And we try to conserve it and see. Only indication for surgery would be if the patient is persistent shock or they suspected collateral injury where the other organs are also injured, and then you examine the spleen and you find that there is grade 2 and 3. So pledgets are used, and when it is more than that, 4 and even 3 sometimes, and it's totally macerated, you would use a polygalactin mesh. So these are the few pieces of information that you should know, and you will be good to go as far as splenectomy is concerned. Now moving to next question, which is a vignette where they've given a 25-year-old woman has intermittent awake right upper quadrant pain. So you know what we're talking about. The right upper quadrant would be having liver there, and she was on oral contraceptive pills. Is a straightforward thing. They've even given a CT scan. Sometimes they'll show you a CT scan picture as well and ask you to make a diagnosis with contraceptive pills, multiple hypodense masses in the entire right lobe as well as most of the left lobe. So the entire liver is involved here, and with oral contraceptive pills in a young female with vague pain and with CT like this, you know this is an adenoma we're dealing with. So do we embolize? Is it vascular? No, it is not vascular, so embolization would not help. So discontinuation is the way to go of oral contraceptive pills, but sometimes they'll just give this as a one of the options. But if it is extended with repeat CT scan of the abdomen 3 to 6 months, you basically don't this is what we go for, because we need to monitor if it is a confluent, both the lobes are involved, left and right. And image based percutaneous needle biopsy of the several liver masses, this would have been true if it were a metastasis, an older patient and with unknown primary, patient's history without oral contraceptive pills, and the patient losing weight, and there were the indications that this patient could be having a carcinoma, unknown primary, or hepatocellular carcinoma, fibrolamellar in a young female also, but then the history would have been different, not one with the oral contraceptive pills. This seems to be a very straightforward question when there's a young female and a vague pain and with no constitutional symptoms, and have patient taking oral contraceptive pills should not get confused. And laparoscopic biopsies of the mass in cholecystectomy, this also would have held true if it were a mass along with the these hyperdense lesions in the liver in both left and right. If the mass was shown, which was gallbladder mass, then the things would have been different. But then again, you would not use a laparoscopic biopsies for and do a cholecystectomy laparoscopically. This fourth choice seems to be totally not true. So what we need to know about 204 question, where there's an oral contraceptive pills and a young female, is there are adenomas and they're managed conservatively, and what is the whole idea behind going for regular checkups with the CT scan follow-ups after 3 to 6 months is they should be decreasing in their both number as well as size. So reduction in the size of an adenoma has to be noted after cessation of oral contraceptive pills at least 3 to 6 months, and if they are not, there's no regression and they're increasing and the discomfort is increasing, then you might have to go for liver transplantation. This is also one of the questions that you might encounter, that if it were an extended vignette where this repeat CT scan had shown increasing number of adenomas and no reduction in the size of the adenomas, then the answer could have been, and the choices, if it were given a liver transplant, then this could very much be the choice as well. Moving on to the next question. This is a picture-based question where they are asking about the method of ulcer healing. And if you see, there's a leg and the medial aspect is shown, and there's a patch applied, and then there's a vacuum-like tube there and vacuum-like. So they're trying to create a vacuum inside, and even method of ulcer healing is a vacuum-based ulcer healing method here. And so what is the idea behind giving a negative pressure in a wound area is to reduce edema, to stimulate growth of granulation tissue. This is how an ulcer bed is called healthy, when there's a healthy granulation tissue in the ulcer bed, and the interstitial fluid, the edema, and also the fluid which collects in the base of the ulcer, that gets sucked with this pressure dressing. And also there's an increase in perfusion. More fresh blood would come to the ulcer, more cleaning of the ulcer happens, and there's increased healing, right? So this is the advantages of a pressure-based ulcer healing system. So what are the pressures? You need to remember is 125 millimeters of mercury, and they are negative, right? So this is what you need to remember for ulcer healing system, ulcer negative pressure healing system. Edema, interstitial fluid, and promotion of the granulation tissue by increasing perfusion and decreasing edema and interstitial fluid. So one thing is increasing, which is leading to healing of the wound, and edema and interstitial fluid is decreasing, right? And 125 is what you need to remember for an ulcer. So another image-based question, which is you can see it's an anatomical snuff box, and important structure which is there in an anatomical snuff box is radial artery, and this is a radial artery aneurysm. Usually there would be one liner also given there, that this is compressible swelling or a pulsatile swelling, then the things are easy. If it were a liposarcoma, the look would have been different, even the location would have been different. Lipoma, usually not in an anatomical snuff box, can be anywhere, but then if this little piece of information is given that it's a compressible or collapsible or pulsating, then the sure diagnosis would be radial artery aneurysm. So, but they're very rare, you should know, and it's a pseudoaneurysm usually after a trauma. So this is all you need to know about radial artery aneurysm. But for lipoma, there could be questions, and the look is the location would be slightly different. It would be the margins are not very clear cut, and it's a soft swelling. The consistency is small. There's a another line which sometimes is given in a question is a slip sign. What is a slip sign? Is when we try to press from one edge of this swelling, it'll slip, and sometimes it's a very diffuse kind of a swelling, and it's not as localized as other swellings are. And pulsatile, compressible, they go in the favor of something like an aneurysm. And the other choices given here, liposarcoma, the location, and even enchondroma, the locations are not the same, not this anatomical snub box. And there will be more history given for making this as diagnosis. Usually liposarcoma would be a histopathological diagnosis, and chondromas also, they are common in hands, but again there would be more in the bones, in the bony area, rather than being in the anatomical snub box. So this is question number 206, was a radial artery aneurysm. Now another spot diagnosis, very commonly seen. This is there was a piercing done for the ear, and then there's a growth of the soft tissue of a scar. This is a keloid. A very typical, most common areas for the keloid is not here, not the ear, but usually the sternum. Women are more commonly predisposed for this. And so the question number 207 is a keloid, right? And it is always is an overgrowth of a scar tissue beyond its margins, and the location here is the earlobe after so the piercing has been done. So how you treat this is using a triamcinolone. If that doesn't work, then you go for excision, wide excision, and grafting if you need to, if the large amount of raw area is. Silicone gel would not work here, and how you can not do any intervention when there is such a big keloid here. When we have a steroid injection, that is triamcinolone, they are usually given in various settings, and they're given in all over. What we are actually preventing here is, what is the cause of keloid formation is fibroblast proliferation, and by giving steroids we are trying to stop that proliferation. And this collagen synthesis happens after fibroblasts, they proliferate and they are laid in the scar tissue. Sometimes they are hypertrophy. This is what is happening in a keloid, right? So females are more predisposed, like in this case piercing must have been done for a female. Now moving on to the next question, another image-based question, 208. It's an alcoholic 30-year-old with features of acute abdomen, and now they have shown a lead in this whole abdomen, but what you notice here is a hematoma, a discoloration of the flanks. This is a gray Turner sign, right, after acute pancreatitis. What is a Cullen sign? Cullen sign is pigmentation around the umbilicus, and this one is a gray Turner sign, right, where there is a collection of this pigmentation is around the flanks because of the hemorrhagic spots and ecchymosis in the flanks, where there's a blood collection here in case of acute pancreatitis, where the pancreatitis is so inflamed, and then there is collection in the flanks, and this has shown in the form of pigmentation in the flanks. So Cullen, you can remember by C as in circle is umbilicus, and gray Turner, when you turn you can see the flanks. So remember like that. This is an easier way to remember. This is how I used to remember myself, that when you turn the patient then you see it. So it's a gray Turner in the flanks and Turner. So turn, if you remember, flanks. And acute pancreatitis is both. Cullen is C, so you make if you make C and you complete it, it becomes umbilicus. So Cullen is umbilicus, right? And Dittle's crisis, you must be knowing. Dittle's crisis is in case of an obstruction in the kidney when it becomes hugely hydronephrotic, and when it empties, there's a mass which is palpated in the flanks and it suddenly disappears. That is Dittle's large amount of, after passage of large amounts of urine, that is Dittle's crisis. And so we're done with this. So 209, most common cancer associated with lymphangitis carcinomatosis. Now this is just memory based question. When we are talking of lymphangitis carcinomatosis, the most common organ involved here is the lung, right? Then it occurs in bronchogenic carcinoma. This is what you need. Also it can occur in carcinoma, breast and stomach, thyroid and pancreas, right? So this is what you need to remember. And the most common source of pulmonary lymphangitic spread is the lung cancer, with breast cancer as the second most. So when this is happening, the lung is the most common and the breast is second in the list. So what are the cancers which spread by lymphatics? You need to remember that by a mnemonic known as certain cancers spread by plugging the lymphatics. So C, certain cancers, C another colon, then spread is stomach, then B, by breast, and P, pancreas, plugging, and lymphatics, L is your lungs, right? And if you include even the so thyroid, the lymphatics. So by plugging the lymphatics, so you can remember the entire list. But the order is like this. The most common would be the lung and then is the breast, right? Now moving on to 210, correction of the cleft palate is done at what age? There is cleft lip and there is a cleft palate. So there are certain ages for all the congenital surgeries. For hypospadias, you need to know what's the age. For orchidopexy, you need to know the age, right? So why there are certain ages for this? Because it makes the candidate idle. The whole goal of performing a surgery for congenital problems is that the child should not be affected by living with certain congenital problem. And when the surgery is performed, it is performed with least number of problems. That is, there are lesser complications without affecting the morbid condition of the child. So based on that, there are certain numbers where within experience the pediatric surgeons have come up with certain numbers. So those numbers are in this. For palate, you need to remember, moving on to question number 210. So this is for palate, cleft palate, it is 9 to 12 months, right? So by 1 year you should be, and lip is little earlier. Why? Because the suction is produced by application over the nipple, and this is how the lip surgery has to be, cleft lip is to be performed earlier, 3 to 6 months. Hypospadia surgery is usually performed by the child becomes by 1 year. You should start planning by 6 months, same as it goes with orchidopexy, right? You should start planning by almost 6 to 9 months, and by 1.5 years the surgery should have been done. So we can go up with a little range of 12 or even 18 months for performing a surgery for. So the child should be having the testes down in the scrotum by age of at least 15 months. And we can start planning by the age of 9 months, because before this we are hoping that the testes would descend on its own under the effects of hormones. So moving on to the next question, that is 211. This is the deepest and the commonest site of subphrenic abscess. So subphrenic abscess, the deepest and the commonest is the right subphrenic, which is usually, so what we should know is that the whole peritoneum is divided by 4 intraperitoneal and 3 extraperitoneal spaces, right? 4 intraperitoneal, right and left subphrenic, and right subhepatic, and left subphrenic and left subhepatic. So these are 4, and 3 extraperitoneal are pelvic area, right and left paracolic, right? So we should know this really well. So 4 intraperitoneal and 3 extra. So here is right and left. So 2 each. So one is right subphrenic and right subhepatic, left subphrenic and subhepatic, right? So we need to remember the diaphragm and the liver, and then just below that. So phrenic is the diaphragm, subphrenic, left and right, subphrenic, and hepatic, subhepatic, right? So which one is the largest in these? The right subphrenic is the largest, and this space is the deepest of the four, and usually it is just below the right lobe of the liver, and in the Rutherford-Morrison's pouch, or Morrison's pouch, more commonly known as Morrison's pouch, right? And in which conditions would you find the space to be involved having pus in it? One is your cholecystitis, and also in any duodenal ulcer, or any upper abdominal surgery. Those are the conditions where you will find this largest space to be involved, and this is the deepest and the largest. So moving on to the next question, 212. This is a lumbar sympathectomy is a principal value in the management of. So you need to know it's an old surgery where we perform the sympathectomy. The nerves, the lumbar nerves are sympathetic nerves. They are excised, and this would not help in skin conditions. This is all you need to remember. It would not help in gangrene. It has a very specific indication where there's a causalgia, where the nerves are involved and the pain is there. It might help in when there's an inoperable arterial occlusion, and when you cannot perform the surgeries to remove this occlusion, bypass surgeries, and there's a life-threatening limb ischemia, and there's rest pain, and but not for gangrene. So it would only help when there's a symptomatic vasospastic disorders, right? So it has a very limited use, and it will not help in improving peripheral patency after even bypass grafts, right? It will not help also in ischemic rest pain, and it will not definitely help in claudication. So a lot of questions are based on where it will not help in, and they would give some indications there, and then you need to know where it will actually help. It will help in causalgia, like this question is there, that in which condition lumbar sympathectomy is now left with the principal value is only in causalgia, but it will not help in intermittent claudication. It will not help in delaying the requirement for amputation, and gangrene of toes will not. What will help is bypassing the occlusion where there is occlusion. So 213. So proper treatment of frostbite would be, answer is C, immersion of the affected part in water, which is 40 to 44 degrees Celsius, and other debridement of the affected part. This is not the treatment. It only, what is frostbite? Frostbite is when the exposure of extremities to cold temperatures. When there's an exposure of extremities to cold temperature, there are blebs which are formed, distal or proximal. So, and sometimes when these blebs, they break, they form an ulcer there, and then the debridement is required. But ideally, immersion of the affected part and keeping them in the temperatures of 40 to 44 would be really effective here. And this has been the treatment for really long. But once the blebs are formed and there are ulcers formed, then we have to manage as the ulcers are managed. And administration of corticosteroids and vasodilators, they are not much of help, and just rewarming the area, this is what is required, right? So that will be all.